All right, and welcome everyone. So this is episode 2. We really appreciated all the people we saw last week for our first episode. It went off great, I thought. We had a lot of good compliments come in, which is always nice to know that people really kind of liked what we were doing and that it was a good program. So I think we're on a good format, but there's always chances to improve, and we're certainly always looking forward to some kind of ideas that you may have. At the end of this, when we do close this down, there will be an opportunity. There should be a survey that comes to you. It's a little 3-question survey. If you'd be kind enough to fill that out, that'd be great. Now, at this point, our first half of this program is going to be general questions. So if you have any questions, feel free to start submitting those on the Q&A box. I did open up the ability to put those anonymously in case you don't want to have your name there. But if you don't mind, go ahead and put it in there. And also if you fill out where you're from, because it's kind of interesting to see where people come from to join this. So I'm waiting for questions, but I can still talk if there's nothing else, or Lori can chime in if she has any questions. How did you think the program went last week, Lori?
Oh, I think it went great. My question to everybody is, how's the flow in the background?
For those that don't live in Illinois, that's not what Geneva, Illinois is.
No, it does not.
I did have some post questions come in after the meeting, and I'm always welcome any questions that you want to send. I know the email comes out. It has my direct email address for this account on it. Feel free to use it and send me a question. I received a question about the PSA talk that I gave last week, and they were asking, where do you get the ISO PSA done? And the only place I'm aware of that does it is the Cleveland Clinic, but they do have the ability to, they FedEx it over there, so you can set up an account with them to have it done for your office. I still agree. I think this may be one of the big game changers in decreasing some unnecessary biopsies. And we're waiting for some questions, folks. Don't be shy. Anything you want to ask. If it's a urodynamics question, we'll do that after our urodynamics discussion. If we don't get any questions, I have no problem with starting the urodynamics early, but we're here to answer general questions just in case you have some. Not too much new and exciting. I saw some stuff coming through on the SUNA EuroConnect about BCG shortages. I thought that might be a good subject to touch on in the future. Have you had much of an issue, Lori?
Oh, yeah. So we have an allocation, our pharmacy and our office. So our pharmacy mixes it. Our office actually, we order it as well. So we've been okay so far, but the problem is that through Northwestern, we have the other Northwestern regions that are not getting as much, and they're sending their patients to us. And how do you deny a patient within your corporation BCG, you know? But we have to kind of keep it for our own patients, and that's the hard part about it.
Yeah, I agree that it's an issue. So I think it'd be another time to kind of revisit that. I'm got a speaker in mind that we'll utilize down the line, because we did look at that subject once before. Speaking of which, we're trying to set up our topics for the going forward. And next week we are going to have Andrea Strong, who's a DNP, and she's going to be talking about telephone triage. So I think that's kind of an interesting thing to discuss. You know, how do you handle calls and some of the legalities behind who's answering them and what you can say and how you should document, etc. So I'm looking forward to that. So make sure you tune in next week for that. And again, anybody in the audience has a question, we'll be glad to answer them. If not, I'm perfectly happy to move on to urodynamics. Okay, I'm going to take that as a let's do urodynamics.
Okay.
So go ahead, Lori, take it away.
Hold on, I'm going to share my screen now. Can you see my screen, Vic?
Yep.
Okay. So on the left is kind of a picture of a urodynamic study or a urodynamic machine, but there's so many varieties of it. On the right are some sensors, but we're gonna go ahead and just start. So the definition of a urodynamic study is documentation of the factors involved with filling, storage, transportation, and evacuation of urine. It refers to a group of diagnostic procedures performed to evaluate voiding disorders of the lower urinary tract, which is the bladder, sphincters, and urethra. So the urodynamic tests are used to measure nerve and muscle function, pressure around and in the bladder, flow rates, and other factors. So symptoms that may require a urodynamic study. Excuse me. Any type of urine leakage or incontinence, sudden urges and overwhelming urges to urinate, and frequent urination, including overactive bladder, problems starting urination and fully emptying the bladder, or urinary retention, weak intermittent stream, suspicion of an atonic or a lazy bladder, basically, obstruction due to BPH or, enlarged prostate, urinary problems after bladder, urethral, and or prostate surgery. So I highlighted some components of the urodynamic study because there's a lot of components. So the uroflow is a simple uroflow. Most people know about the uroflow. It's a measurement of how much and how quickly you urinate, rated in cc's per second. Post-void residual, the urine, of course, that is left behind after urination. So this is where we get into the urodynamic part of it. The cystometrogram, or the CMG, otherwise known, the measurement of the pressure within the bladder. Bladder pressure is measured during fill. So when we fill the bladder, we start the cystometrogram portion of it, as well as the abdominal pressure, which is the estimation of the other pressures from the abdomen outside of the bladder, from the rectal or vaginal pressure. And these things are important to kind of know before I get into the nitty gritty, which is at the end. Detrusor pressure is the estimated measurement of passive and active forces of the bladder obtained by subtracting. And this is going to be at the end, but the abdominal pressure from the vesical pressure. So vesical pressure minus the abdominal pressure means the detrusor pressure. So leak break pressure, this is measurement of the pressure at the time of leak. So when somebody coughs, sneezes, whatever, if they have stress incontinence, we're measuring that pressure when they leak. The EMG represents the pelvic floor muscles' electrical activity during filling and voiding. We'll talk about that later. Pressure flow study. This is basically the measurement of the rate at which the urine expelled from the bladder relative to the force of pressure of pushing urine out. So we're trying to look at that pressure when they void. So patient instructions for urodynamic study, so not all offices do this. We don't necessarily do this, but a lot of them do. So to stop the following medications 3 days prior. So these are anticholinergics that some places recommend they stop 3 days prior to the urodynamic study because it can interfere. So that's the ditropan, the Detrol, the Enablex, Oxetrol, Sanctura, the Vesicure, Mirbetriq, and Gemtesa, which I still can't pronounce. It's pretty new. So it's Gemtesa or Gemtesa. Anyway, complete a 2 to 3 day voiding diary and bring to the appointment for review. And this is important. We'll talk about it later. We want the patients to come to the dynamic study with a full bladder, but of course, we're doing that simple uroflow prior. No restrictions on diet or activity, and the test takes approximately 60 to 90 minutes. So this is the patient's voiding diary and history are reviewed. So when the patient comes in, we look at the voiding diary, we look at their history. I just put this example of our voiding diary. So what we want patients to do is put the time, what did you drink at the time? How much did you drink? Amount urinated, amount of leakage. And this is more for stress urinary incontinence. So drops, medium soaked, and activity. What were you doing when you leaked? Did you leak without even knowing it? Did you leak when you cough, sneeze, things like that? So of course, like I said, when the patient arrives, they do the uroflow. We do put a straight cath in and check the post-void residual because we want to know how much they voided. The catheterized urine will be tested to rule out infection because you never want to do a urodynamic with an infection. And so then we place a small bladder sensor into the bladder, which is the bladder pressure. And another sensor is inserted into the rectum, which is the abdominal pressure, and the electrodes will be applied around the anus and to record the pelvic muscle or the pelvic floor's electrical activity during the study. So after all of this is connected, basically the bladder, abdominal sensors, and the electrodes, the patient will be asked to cough to check for placement. And then we start filling the bladder with water at a rate of 50 cc's per minute. But if the patient has a known history of overactive bladder or small bladder, we tend to try to fill them a little slower to prevent abnormal contractions. During the study, the operator will monitor for activities such as bladder contractions and leaks. And like I said, this is very basic. There's a lot of things we're looking for, but I don't want to overwhelm anyone. The patient may be asked to cough or Valsalva during the study to check for leakage because especially with SUI or stress incontinence, we want to have them cough or Valsalva and try to see if we can get them to leak because we want to know what that pressure is. Is it a mild leakage? Is it a large leakage? Is the pressure really high when they leak or low? And so then we're actually asking the patient when they first have the sensation to void, desire to void, and strong desire and the capacity. Because we want to know if they have a delayed sense to void or, or they feel like they have to pee right away. So we want to know kind of those things. So when the patient reaches capacity, they will be asked to void for the pressure flow component to the study. I'm going to kind of go to so this is an example of a uroflow, or excuse me, a urodynamic that we did probably, a little while ago, looks like in January. So this patient happens to be 82 years old, a male. He was complaining of urinary frequency, and he has a history of incomplete emptying. So if you look at the beginning of the study on the top where it's yellow, we had the patient cough to check for placement, like we discussed. So it's hard to see, but when they cough, the pressure should be the same as the abdominal pressure. As the study goes on, you can see that the pressure is a little high for his bladder. That's the PVES on the top. The abdominal pressure is pretty quiet, but keep in mind that anytime a patient moves, sneezes, coughs, raises a question, it's going to be a little bit off. So the abdominal pressure is pretty quiet throughout the study. The vesicle pressure is a little high But what I want you to see is that at the end of the study, okay, number one, the patient has a delayed sense to void. So, and I'll show you the numbers after. So, but what I want you to see is that you see the yellow, and then you see the blue down on the PDET. That's a vesicle pressure. That's a detrusive pressure. And so we know that the patient wasn't doing anything at the time of the void. So the void actually shows that he has some pressure. He's voiding pretty good. And then when he's kind of stopped a little bit, and then you can see the yellow rise and the blue rise. That's basically him pushing the void out. Right there. So my points is that, so he had the sense to void at 474. I highlighted these. Sense to void at 474. The desire to void was 483. His capacity where he felt like he really had to go was 506. So obviously he had a delayed sense to void. The urge, so let's see, the void was 562. The total volume infused was 563. And he only peed 291, which means he had a residual of 272. So after that scenario, the patient was diagnosed with a little bit of obstruction because his pressure was a little high through the study. He had a little bit of atony of the bladder because he didn't feel like he had to pee for a while. Mild obstruction, obviously incomplete bladder emptying. So number one, the patient needs to be informed of bladder irritants. When I looked at his bladder diary and he just drank coffee and Diet Coke all day, which I love Diet Coke and I drink it all day, but he needs to kind of back up on that. So then we told him he needs to intermittently catheterize himself twice a day. Just try to help him so he doesn't have to get up at, a lot at night, and hopefully control it and make sure his creatinine or his kidney function doesn't get worse. And then he's on tamsulosin, so he's going to continue tamsulosin, and then he's going to consider prostate surgery to improve the obstruction. It may not help him from catheterizing because he does have somewhat of an atonic bladder, but it may give him a little bit more freedom. So after the urodynamic, we want to make sure that the patients know they're going to have maybe a little bit of bladder and rectal discomfort after a few hours. They may have a lot of frequent urination and slight burning. And that's for the first urinations afterwards, although I tell people probably the next day, they'll be fine. Blood in the urine, it's infrequent, but especially with those with enlarged prostates and difficulty catheterizing, they may have blood in the urine. And then they should notify the provider or the office if they develop symptoms like pain, urgency, burning with urination, especially few days after the test, because we want to rule out a UTI. Encourage the patient to drink a lot of water and instruct the patient to schedule a follow-up appointment with the ordering provider to review the information. So the interpretation of the urodynamic study, it's ultimately up to the provider, but the more, they're not the ones doing the urodynamics. So the more information they can provide, the operator can provide, the better the patient's diagnosis and treatment options, because we can tell the providers what is going on during that urodynamics. And the more we can tell them, the more that they're going to know, because it's hard just from a piece of paper. Any questions?
If you can switch off of the share screen, I will read some questions that I have coming up. All right. So I will read this first one from an anonymous attendee. I work at Sanford in Fargo, North Dakota. And we have the same issue with BCG. Fargo has enough BCG, but outside of Sanford facilities are struggling to find enough BCG. I also think telephone triage would be an excellent topic. So thank you from Anonymous. Those were some good points that we covered. Alab Adriano just asked, I have just started using air charge urodynamic, the sensors. I'm having issues during the test where the P det goes to the negative without any activity in paid. I'm not sure what that meant. During training, I was told to re-zero during the test. I've only zeroed at the start of the test. Any suggestions? That's a really good question.
That's a great question. And I think that when you go out into the negatives, number one, you've got to check placement. You got to make sure it's in the bladder. You can adjust it. And believe it or not, I'm going to tell you a story real quick about what happened to us, or to me, that I put in the sensor too far into the bladder and actually went up the orifice of the ureter. And I actually caused hydro on a patient, hydronephrosis. So what I would do with those negatives, I mean, every machine is different. So I'm able to re-zero only once in the beginning of the study, which I hate because sometimes you get that negative. But I would check your placement. And eventually when the bladder fills, I think it ends up getting into that positive. So I wouldn't worry about it if it's like -1, -2, if it's less than that. What do you think, Vic?
Yeah, I agree. And by the way, I've also catheterized the ureter by mistake.
That's horrible.
And a word of warning, if you do urodynamics, whatever you do, always start that infusion very slowly, then increase the speed, because it doesn't take much pressure in the ureter to have them screaming. So unfortunately, that's always been my habit to do that, but hard to believe. I mean, as hard as it is with the cystoscope to catheterize a ureter, to do it blindly like that is amazing.
Yep.
But yeah, I've had the kind of what Olive's talking about too with the re-zero situation. And sometimes it's, they use air can leak out. So sometimes there's an issue with the charging. It didn't charge properly. There was a connection that wasn't good either. So that can also have an effect on it. So I do have a couple more questions coming in. Susie Swain had sent these in prior. I thought this was a good one to ask. What are some important questions to ask patients prior to urodynamic studies?
I think that the most important is to ask them what their medications that they're on, especially GU medications. I definitely think that the most important is that avoiding diarrhea. That's gonna give you so much information, because it's gonna give you how much the patient can hold. Because sometimes when you do your urodynamic, they'll say, oh, on the urodynamic, they'll be like, I have to pee after 50 cc's, but on their voiding diary, it says they can hold 300. So you really have to differentiate that.
I kind of agree with the questions, what medications are you on, because it sets you up for things that you want to be more careful of, such as people that are on blood thinners. When you're passing a larger cath, I always say that the most dangerous catheter to pass is the urodynamic catheter. And the smaller the catheter, the more dangerous it is. A lot of people think just the opposite. They're worried about a big catheter. You're not going to get into too much trouble with a 16, 18 French catheter, because it'll just buckle if it hits an obstruction. But these smaller ones, they can, kind of bury themselves into somebody's prostate and things like that. And nothing worse than doing a test and having somebody start bleeding because they're on blood thinners. So, and not that you can't do it with blood thinners, but I think that, you want to be more cautious if they're on blood thinners. I have a question from Robert Bullingham, and he's from Los Angeles. What do you find is the best to hold the pressure electrodes in place when inside the patient? Ooh.
That's a great question, because that's urodynamics, unfortunately, the hardest part, it's not exactly the study itself. It's actually trying to get everything to stay in place. And so what we do, I guess the question is, are you talking male, female? I guess I could talk about both. So the male, what we do usually is put a strip of tape over the head of the penis, but like towards the tube, and then squeeze it on the tube. And then we put another one around the head of the penis, so it stays right there. So there's kind of a hood that the patient could still pee through. Now, as far as the female, we put tape on the inner thigh. We give it a little slack, because when they're getting up to get on the commode, you want to be able to give it a little slack. But as much as you can, because females, especially with the small urethra, they fall out really fast, or they get misplaced. So that's what we do. What about you, Vic?
Yeah, let me get this drawing board up here for me to use. So this is my secret. This is your piece of tape. I rip it right down the center like that. And it's probably not as good a picture, but so here's the male urethra. And what I do is I have the piece of tape coming like this, and the ripped flaps that I produce off the side, I then wrap around the tube. That makes sense? So you've got the same thing you're kind of saying with two pieces of tape. I use one piece of tape and just split it down the center, and then wrap it around the tube to hold it securely. And that's worked out pretty well for me. The other thing is, when we talk about the female bladder, the simplest thing to do is put enough catheter inside their bladder so that it can curl around a little bit and not get urinated out, because a little tiny bit in their bladder, the amount of pressure that a female can produce easily will urinate out the catheter, and then you're back starting all over again.
And I think one of the really important parts, and a lot of people don't want to do it, but I think it's important, is shaving. Get rid of the hair, because the hair is going to cause a lot of problem. It's easier to tape, they stay in better. So if you're putting those electrodes around the anus and they have a lot of hair, shave it. It's going to make a world of difference.
Yeah. Good question. Some good answers. Let's see. I have another one here. Let me just get it ready where I can read it. From Susie Swain. Is urine dipstick necessary prior to urodynamic study if patient has an indwelling catheter?
So that's a great question. We still do urodynamics if they're asymptomatic. If they're asymptomatic, then we will still do it without antibiotics. There's no reason to put them on antibiotics. I think people think differently in other places, but for our group, we do not put them on antibiotics because they're colonized, and there's no reason if there's not any symptoms.
So would you do a dipstick prior to see whether they're...
Oh, a dipstick?
That was their
No,
question. Yeah.
Absolutely not. With a Foley catheter, I would even check a urine period. Not at all. As long as they're not having any symptoms, there's no reason to check a urine.
So I'm going to share with you a couple articles I did look up on. And I think there's, as you kind of alluded, there's some mixed feelings on how you would approach this. So best practice policy statements for antibiotic prophylaxis in a non-index patient. So as you kind of said, we don't recommend urodynamics as antibiotics after urodynamic testing. And it's been pretty well proven in the literature as not being necessary. And I thought this one was kind of interesting in the Annals of Rehabilitation Medicine was, should we delay urodynamic study when patient with spinal cord injury have asymptomatic pyuria? And that's kind of what we're talking about with that catheterized patient, that, they can have asymptomatic pyuria without, necessarily having to cancel their treatment. I mean, their urodynamic study. And the conclusion showed no difference was found in the prevalence of post-urodynamic UTI based on the presence of pyuria in the pre-urodynamic urinalysis. Should be performed even in SCI cases of pre-urodynamic pyuria without increasing the prevalence of post-urodynamic UTI if prophylactic antibiotics are administered. So I think that both of those studies kind of give us the same conclusions that we had with a little bit of evidence behind it. And I pinned myself and I can't unpin myself. There we go. Don't want to hog the screen. So yeah, that was a great question. Let's see here. Kimberly Flowers. I'm really interested in this topic, but my husband broke his ankle and had surgery yesterday. I have seen and or heard about 5 minutes of today's program. Oh, okay. Can I get access to your PowerPoint? Not sure I'll have time to view it later either. So I think probably the easiest answer to that is you've got access to the whole thing, the actual presentation. You can go to UroNurse.com and it will show up probably sometime later tomorrow. It's always being simultaneously casted to YouTube live. So people could watch that as a choice, but you just can't ask any questions. And I do see there was a few viewers on our YouTube channel. That it also records that, and I'm able to then put that feed onto the UroNurse.com site too. Or you can go to YouTube and follow that channel. Either one will work, but it takes me about a day before YouTube lets me edit out some of the early stuff. So I like to condense it down to just the program. So, and sorry about your husband's ankle. Wow.
Yeah.
So any other questions? Feel free to go ahead and put those in. I'm going to throw a question out there for you. You had mentioned that that patient you gave the example about, he had early BPH. So what's kind of your threshold on detrusor pressure where you start calling it obstructed versus non-obstructive?
That's a great question. So luckily our machine will spit out a formulation where it'll say whether they're obstructed or not. In this particular patient, he was mildly obstructed.
Mm-hmm.
So I'm not quite sure, you're probably better at this than me, as far as the pressure at which they determine whether somebody's obstructed. I mean, I think this guy was definitely somewhat obstructed, obviously, because he couldn't urinate all the way, incomplete emptying and whatever. And he was trying to push to void. So what's your thoughts?
Yeah, so I think what you're talking about, and I probably have the name wrong, but I think it's the Griffin chart where they look at the pressure and flow and compare them. And
Right.
based on that, it forms an angle, and it'll show
Right.
it's what point they consider it non-obstructive and obstructive. So
Right.
kind of in our dealings, anything up to about or less than 12 cc's a second is considered a lower flow. So we're looking, the definition of BPH is high pressure, low flow. So if they have a lower flow rate, 5, 6, 7 cc's per second, and higher pressure, generally over like 35, it's kind of a debated as you go to urodynamic meetings as to what that pressure should be. But certainly, you start seeing 45, 50 centimeters of over water, even though we use an air charged system, that is considered obstruction. So if they have high pressure, low flow, that's the definition of obstruction.
Yeah, I think that the problem with this particular patient is the hard part is that even if he does have a prostate surgery, whether it's UroLift or TURP or whatever, he still has apnea of the bladder. I mean, like he's not feeling like he has to pee until he's on 500.
Yeah.
So the hard part is, he can probably pee better afterwards, but is he really going to empty his bladder? And that's why I think that the CIC was important for him because he may have to continue with that,
Right.
after
Yeah.
the surgery if he does do it. So
Yeah. So that's a good point. So that's when you're looking at the um, sensations of the bladder. So if somebody has what we call the delayed sensation, then we know that they probably have had blockage for long term, and they've had what we call detrusor decompensation. They just don't really have the ability to squeeze as hard sometimes because their bladder's been overstretched. And you can see
right.
a low flow situation with low pressure. That's just the opposite of kind of what you saw, where it was a higher pressure. So at least he still has a good detrusor there that can kind of push urine, but there is some blockage. So
Yeah,
maybe on intermittent cath, maybe somebody who could have a procedure done to help open it up and get that decompensated bladder to compensate a little bit better. But
right.
certainly the sensation was an issue too, because that's the ones you worry about. And then when we talked about what questions, that's a history of diabetes is another
Yeah,
issue, or spinal cord injury, and it doesn't necessarily mean the guy who came in a wheelchair, because
right.
I had spinal surgery done years back on my thoracic spine, and never really considered myself spinal cord injury until I saw a new neurologist, because my other guy retired, who said, well, of course you've got that problem, you've got spinal cord injury. And I'm like, oh yeah, I guess I do. So any
Yeah.
thing that can cause issues can cause some of those bladder issues.
So I want to
Uh,
throw this out there as far as like little things that you say to patients when you're trying to explain things. So one of the things that I tell people that have an atonic bladder or are in your urinary retention, it's like your bladder is stretched out like a balloon, and it never really goes back down to its normal shape. And they get that. So I'd be curious to see what other people will say about, little things they say to patients that make sense to them.
mhm. Yeah, that's a good point. We have a question here. Any suggestions if the patient can't urinate after the test with sensors in place? Do you take them out? That's like the worst thing that you can have happen, right?
You know what? I think people get in their minds that they're not able to urinate around the sensor. And I think it's just all in their head. But at some point, if they can't pee, we just end up taking them out. I mean,
Yeah.
you can't sit there for an hour. So, and then you probably should do a uroflow. You could still do a uroflow afterwards.
Yeah.
It's not necessarily the pressure flow, but take the sensor out and actually have them pee as a uroflow.
There is a device too out now. Some people, they just freak out because they got some tube in their
Yeah.
urethra. There's a thing called the Euro cuff. I don't know if you're familiar with that one or
Oh,
not.
I am, but
It's
no, we haven't done it.
I call it the poor man's urodynamics test, because it doesn't compensate for abdominal pressure. So if they're sitting there pushing with
Right.
their gut, you don't know.
Right.
But it's take that out of the equation. It is very non-invasive. All it is a little pressure, kind of like a blood pressure cuff around their, it's done only on their penis. And it basically, when they start urinating, will cut off the flow. And then that gives them a flow rate and a measurement of indirectly of pressure. And it kind of can give an indication whether they have a blockage or not without having to catheterize somebody. Because
Right.
one of the things I learned early on in my career is how people react to things you'll never be able to figure out. The big burly truck driver comes in and he'll pass out because you catheterized him just out of a vasovagal response.
Right.
So I'm always really careful. I always have my men do their voiding test standing, so that they I can kind of get the best results. There's a lot of good studies that show men have a better result standing than sitting. But if they're feeling a little queasy or something, then by all means have them sit down.
So I guess my question to you, Vic, is that, so do you have, like, for your urodynamics, do you have patients stand or sit?
For males, stand.
Males. Oh, you do? So you don't come out with a complete mess?
I have a trick. Here I go back to my drawing board. this one I should patent. The bottle that you get, what's that 1 liter bottle that you get that the water comes in? I can't remember what those are called. Sterile water comes in. Anyway, those bottles, almost every office has those. I go and I cut this end off and use it like a funnel. So it's got that little area where the cap would be. And then I take silk tape and I put it around the edge so that it's not a sharp edge. But if you get scissors, cut that off, you just created a very inexpensive funnel. And I also have seen, or I've tried it. Some of the gas stations used to sell these funnels for putting oil in your car. They're made out of paper and they're super cheap. I picked up some of those for patients. And so I have them aim their penis through that. Now, there's a question, does that actually deflect or slow down the flow of urine? And I don't think so. I think it doesn't interfere.
That's a great idea.
And not spraying all over the office.
That's a great idea.
Worth its weight in gold. Well, see, that's why people come here, to get great ideas, right?
Yeah, that's a great idea.
But yeah, somewhere I did a talk and I had a patient give me permission to take a picture of him from the side so you couldn't see who he was using it. And it's really impressive when you see how well it works. So I strongly recommend that.
That is a great idea.
The other thing I would say about the patient who can't pee. I mean, there's some people that can't pee when they've got an audience, and even one person in the office doing urodynamics is bad enough. Some people have multiple people in the office. If there's a physician that's watching, and all this observing is enough to make some people not able to urinate for sure. So the one thing I always do is, if I feel that I'm comfortable with the patient's not, at the least bit queasy and not going to pass out on me, is I say, I'll go ahead and step out, just take your time, relax, and try to go. And I would say about 80% of the time, they're successful at urinating. So sometimes it's just having a person there watching. It's just too much to mentally grasp.
Yeah, I always
get a little
walk out.
privacy, that helps.
Yeah, I always walk out for them to pee, of course, if they're not having any disease spells or anything. But even with voiding trials, like I'll always walk out. And I'll even say that, if you want to go into the bathroom, it feels more comfortable. I still want to see what comes out. And even if they want to just go into the bathroom and pee, I can do a residual scan with an ultrasound afterwards. I don't have to. So if they're more comfortable doing that, I'll do that too, because they get nervous,
Yeah. And I think that's a good point. As a practitioner, we want the best test possible. So we're invested in having them being able to give us results. But it's not always going to work that way. So you're dealing with people, and people are funny creatures. So you have to be, kind of comfortable enough when you're doing these to say, let's get the most information I can about the patient, which, like you said, maybe, hey, go to the bathroom, let me get a post-void residual and just see what that was.
Right.
Do you catheterize your patients before you put in the urodynamic tube?
I do. So, we always do. So what we do is, when they come in, we'll have them pee and check their urine when they come in, but then we'll also catheterize them to get the post-void residual. We actually just recently had a patient a couple days ago that when she peed, we always check that urine, but it was kind of non-conclusive, and she was having kind of she was having like vague symptoms. So we decided to catheter her and get a urine sample, get her actually true post-void, and then we checked her sterile sample. So the best way to get, obviously, the UA is from the catheterization. But we always have them pee first, just because if they're blatantly infected, we're not going to do the procedure, obviously. It's just going to give you all these false results.
Yeah. That's definitely a good point. We do the same thing. We always catheter, have them urinate, check a urine sample just to make sure they're not grossly contaminated. Somebody who's not wearing a catheter and has an active urinary tract infection, we're going to treat, then do the urodynamics. Because obviously overreactive bladder can be caused from a UTI. So you don't want to misdiagnose
Right.
that. And
Right.
then secondarily, we catheterize to get a post-void residual in a more natural setting. And then when they go and they void, such as the patient that you showed the example of, had a 200 and something cc residual.
Mhm.
What was his pre-residual? And I always report that because I think it validates your test. So if the patient voiding with just going to the bathroom left 200 cc's behind, and then during my test left 200 cc's behind, it's a pretty good
It's
test.
valid.
Yeah, it's at least an extra validation step that I think is worth having.
Yeah.
The other thing is, I think when you place a catheter, you get a feel for, especially in male patients, you know, the urethra. Is there any kind of tricky curves, corners, turns, things that you're gonna encounter? Early on, the TDOC catheter, that's the air charge catheter that Olive had alluded to starting to use, only came in a straight catheter. And I actually, it was invented by a urogyne who was doing urodynamics in his office and got tired of all the issues you had with water urodynamics. And for those of you that do urodynamics and did water, you know what I'm talking about. But the air charge kind of took that away because it's much more reliable. But it only came in a straight. And for a man, sometimes getting a straight catheter is not going to work. You need a coude. And so I really talked to this guy and said, hey, you know, you need to create a coude catheter. And so he said, okay, he says, would you mind testing some? And I'm like, send them. So he sent some of the prototypes to my office, and I was able to go and give him feedback, and they kind of came up with, I thought it's a pretty good catheter, to the point that most of the time, if I had a male patient, I'm using that over a straight. But definitely if I had trouble putting in a straight in regular straight cath, I will.
Yeah, I try the straight cath usually first, and then if we can't, then we'll do the coude.
The coude, yeah.
Yeah.
Do we have a comment from Northern California? The tips and tricks are great. So kudos to you there. Tips and tricks coming out. Good.
We got lots of tricks, so keep asking. I mean, the hardest, like I said, the hardest thing is the placement of these catheters and the artifact. The artifact through your urodynamic study is awful. You're trying to figure out what is going on when their abdominal pressure goes up, their bladder pressure goes up. You know, are they coughing? Are they sneezing? Are they pushing? Are they moving? Are they, you know, we try to keep the patients as calm as possible. That's the key. Tell them to put don't have them cross their legs, don't have them cross their arms, have them in a relaxed position is the best test. Of course, it's hard with some of the elderly, but the best you can do.
And sometimes knowing that history too, pulmonary patients that have pulmonary problems where they're doing a lot of heavy breathing or a diaphragm assisting, they're going to have these wavy patterns with every breath they take.
Yeah.
And sometimes obesity can cause that to be more prominent. They have a question here. What type of urodynamic machine do you use? Any alternatives to the outrageously expensive TDOCs, which I won't argue. Let's take the first question though. What urodynamic machine do you use?
Oh, so we use a Labrie. It's probably the one we currently have is about 5 years old, but we're getting a newer one, which is probably more expensive. It's still a TDOC. So of course the TDOCs, I mean, those catheters are super expensive. I think they're $5 something for the straight, and for coudes it's like even more. I mean, no matter how you look at it, it's expensive. The only problem I have with the machine that we have now, and I don't know if anybody can attest to this, but the machine we have now makes you scan a barcode on the catheter package. And so if something doesn't work right, you have to redo it. We have to grab a new catheter because you can't rescan a new barcode. And I think it's just their way of making more money, to be quite honest. I've never seen that before, but that's so I don't know anybody else's comments on that.
It could be they're concerned that because of the expense, people are soaking them and reusing them.
Ew. What?
That's the only thing I could guess why you have this.
What? Do people actually reuse them?
You don't know what stuff goes on.
Oh my God.
I'm not saying we do. I don't promote it.
Okay, no, I don't know.
But I do know what
Gross.
happens in the real world. And there are
Oh,
some
okay.
offices that reuse. I mean, let's face facts. Prior to 2000 and something, when the FDA kind of came down and said that, intermittent cats cannot be reused, they're single-use items, even though it said it on the box, most people were soaking them in vinegar or all sorts of things that kind of reuse them, and they weren't buying new catheters because the government didn't pay for more than like 8 catheters. Then they suddenly said, well, single use, now we have to pay for enough catheters to make that work. And that's when the single use really became popular.
Wow. Interesting.
Alternatives. Oh, urodynamic machines. I've used a Bard machine that came out when it used to be like the sensors were fiber optic pressure sensors. Those were a real trip. I used a second machine that I loved, and I can't think of the name of it right now. But nowadays, there's only a couple of choices in urodynamics: Laborie and Prometheus. I don't know any other companies out there. I mean, if somebody else has a note, please let me know. But it's those are the only two I can think of. Laborie kind of cornered that market. They bought everybody else out.
Now, people may want to know that with Laborie equipment, and I hope no Laborie person is going to listen to this, but if you go through SRS Medical, you can get those catheters cheaper than going through Laborie. So all the equipment and stuff, and that's just my experience, that obviously Laborie is going to want you to buy Laborie items, but if you go through SRS Medical, they're cheaper.
I think if you're part of one of these big buying groups too, some of those you can look at for buying. There are alternatives. I think the water charged catheters are still available, the water sensors, but boy, I tell you what, it's worth the price, although they are expensive, to have the TDOCs. And John Lynn just sent a information in here, and I think he's kind of on the same place that we are. It's a total scam by Laborie. So could be. Never heard of cath reuse. I wish I could tell you. I did research for. I was one of the authors with the SUNA and AUA on prostate biopsy infections, and we kind of looked at what was being done and some of the poorly reprocessing of equipment that was taking place that led to Pseudomonas infections, etc. So trust me, it's out there. I wish it wasn't. I don't advocate it. And I do agree, reuse by the same patient with intermittent catheter is reasonable. I think it makes. I mean, I could tell you that we've taught that for years and never had.
Right.
I have patients that had the same catheter, and they come in with this ugly looking thing, and they still don't have an infection, but they've been managing with it. So, and here somebody just did say UroGPO. That's the one I was trying to think of, because we're part of that buying group to save money. Absolutely. I mean, if you're buying it right from Laborie, you're probably paying premium for it.
And we were even talking about the printer paper for our Uroflow machines from Laborie. They were charging like $42 for one roll.
Wow.
But you buy it outside of that, it's like, I think it was like maybe $51 for, but you get like 4 or 5 rolls. I mean, it's incredible.
Have you experienced any shortages on any of that equipment? I haven't seen
so far not. No.
I think urodynamics is a small enough niche that there's probably enough equipment out there still being made, but it's everything else. I just got a notice from the company that makes the Urojets, the lidocaine jelly, that because of the lidocaine shortage, they're running short on their supplies too. So there may be a shortage of those, of the glidos.
Yeah, we've been able to get it so far, but I've heard of that. So I kind of over ordered lidocaine, so I have an overabundance just because I knew that was coming. So,
and and that's, I think, part of the problem, and that's kind of human nature. When you hear about this, what do? You stock up. And our in big offices for sure, they don't want to run out of any of this stuff, so they really stack up, and that
Right.
starts to cause. I mean, that's helps make the shortage. So, well, wow, this has really been a great discussion. I think we're getting pretty close to the end of our hour here. If there's any more questions from the audience, feel free to send those. If not, I do want to alert you to the after party. So what's the after party? If you just want to hang out and just talk about some of the things that we were talking and discussing, or ask questions that you want to be able to do live, I am going to open a Zoom meeting after this. I did send a link with the link that you got for today's meeting directly to that. So as soon as we close, I'll open that up. Feel free to come and join us, and you can be on live and talk to us and everything. We're trying this out to see if it'd be fun. It's totally just a chit chat type session. We're not going to be asking questions or anything like that, but we're there to ask us if you got some questions or concerns that you didn't get answered today, or just want to talk about other things. Also, please feel free to fill out the survey that I hope comes up. A lot of this stuff we're learning as we go. New tricks every time we try it. We'll get a little bit better. So we hope to continue this. As I said, next week we do have Andrea giving a talk on telephone triage. Looking forward to that. So we'll tune in for that. Fran Foley, hey, how you doing, Fran? Just sent a question here, or actually a comment. Instead of Eurojet, go to Glido, less expensive, no sharps or glass. And that's, I'm showing my age because I did say Eurojet because I used Eurojet for years, but I've had two Eurojets. I've had two Eurojets in my career crack and explode in my hand. Thankfully, because I had gloves on, they didn't cut me. But
here's another option that we used to do because we were low. You can actually inject 2% lidocaine without epi into a gel, which they have bags of gel, mix it up and pull it up into a slip tip syringe.
Yep.
And you can use those. We did that all the time when we had a shortage or we couldn't get it.
Yeah. Those bags, I think, have disappeared. There was some issues with, there was some lawsuits that came because of the companies that were mixing these things. These mixing houses were not following all the strict protocols that are necessary to provide guaranteed safety. And there was and so a lot of them quit doing that. So
we also stopped doing lidocaine jelly on females. And I hate to say that, but they have a short urethra. It's not going to make a difference. We just stopped doing it on females. We only use it on males now.
So I got a couple last comments before we switch over. John Lynn said, great job, John. Thanks. Appreciate it. Fran Foley, who now let me know she's from Worcester, Massachusetts. Oh, God, yeah, Massachusetts. Sorry, murdered that one. That's why I live in Indiana. Fran did make the point. They don't roll off the operating room table. Exactly. All right, folks, I'm going to end the meeting. It was great to see you talking to everyone, and we'll have another great discussion next week, and join us for the after party. Oh, the other place for the after party is UroNurse.com. Just click that button. It'll transmit you automatically to that party. See you later.
Thank you. How do I get to the after party?